Welcome to Ethics for Lunch. My name is Mark Hughes. I'm co-chair of the Ethics Committee here at the hospital and also faculty member of the Berman Institute. This is our monthly session where we invite members of the community to come and hear about a topic of importance for the hospital. This is co-sponsored by both the Ethics Committee and the Berman Institute of Bioethics. We appreciate that support. We encourage you to let us know that you're attending, and we have this up here for CME purposes. So if you have a smartphone, can text the 16888 number to that number. That will verify your attendance and also helps us for our CME accreditation because we have a full house. It's great to see so many people here. I'm going to turn it over to Sharon Owens, who is a nurse practitioner on the cardiac surgery service and also a member of the Ethics Committee, and she'll talk about our panel.
Welcome, and thank you for coming and participating in this important topic. Ethical decision-making for patients with substance use disorder requiring repeat cardiac valve replacement surgery. So certainly the practical and the ethical considerations of repeat valve surgery in patients with substance use disorder is a source of discussion and controversy among clinicians. Our objectives are going to include identifying some of these ethical principles and values in conflict when considering people for repeat heart valve replacement surgery, and also discussing some of the potential impact on healthcare institutions, the pros and cons of surgery, and reviewing some of the current knowledge. I'm going to right now have our panel introduce themselves and the role that they play in the institution.
Hi, I'm Janice Wallop. I'm a nurse practitioner on the cardiac surgery service. I work on the CBPCU, which is the step-down unit in the cardiac surgical ICU. So I primarily manage patients post-operatively after their valve replacements, but also at times we have patients coming to us prior to surgery, waiting to have their valve replacement surgery done.
Hello, my name is Krista Strons. I'm one of the social workers on the CBPCU with Janice and also the CBSICU. We have two social workers and we assist the team with some strategies coming up with a plan and also helping the patients and the families cope with the situations that they're in at that time.
Good afternoon. I'm Diane Rose. I'm with the State Substance Use Consultation Service. Been here for about 30 years, working in various capacities. Currently work under care coordination for people with substance use disorders.
Good afternoon, I'm Patty Burdee. I'm a nurse and I have had various roles in my 32 years here at Hopkins. Currently working with the substance use consult team, and we do bedside interventions for our complex patients as well as we place them into facilities, substance use treatment programs if they're ready. If not, we'll give them resources and hopefully they will find a recovery at some point in time. But we always want to instill hope and motivation for this very vulnerable patient population. And I'd also like to introduce, we have two peer recovery coaches here with us, and I'd like them to introduce themselves. You can just stand up.
Good afternoon. My name is Alethea Bronson. I'm a peer recovery coach, and I work with the Substance Use Disorder Service, and April will be 2 years of this year that I've been working here and with substance use. I help motivate, encourage, and support any patient, whether they using or whether they tobacco, anything. I'm here to support them in anything that they need.
And Dale.
My name is Dale. I'm a peer recovery coach as well, and I'm the same advocate, assist with any means necessary with individual substance use disorder.
My name is Matt Kilich. I'm a cardiac surgeon here. I'm often involved in some of these ethical dilemmas. I look forward to everyone's insights and offering my own insight.
Thank you. I'm going to just give a very brief background of the issue that we're going to be discussing, and then we'll move right into the case study. So infective endocarditis, for people that are not familiar with it, is an infection of one or more of the heart valves that occurs through an infection of the endocardium that may extend into the myocardium. There are many risk factors for infective endocarditis, some of which are cardiac. Could be a prior history of infective endocarditis. It could be a prosthetic valve, history of valvular or congenital heart disease. And then there also are several non-cardiac risk factors, including intravenous drug use, indwelling intravenous catheters, immunosuppression, or dental or surgical procedures. So, sort of at the same time as we are having an opioid crisis in the United States, we are also seeing more and more cases of infective endocarditis. So between the years of 2006 and 2013, heroin use nearly doubled in the United States, increasing the overdose deaths and also markedly increasing the rate of endocarditis related to drug use. So rates of hospitalizations increased between the years of 2000 and 2008 from about 8% to 12%. And then the proportion of drug use-associated endocarditis hospitalizations increased from 7% to about 12% between the years of 2000 and 2013. So very much so increasing the use of resources and sort of the discussion of how are we treating these patients and are we giving them the right things to help them. This is just more of a visual of that. So our case study is going to revolve around a woman who presented to the ED with fever, chills, and fatigue. She had a history of intravenous drug use, and she also had mitral valve endocarditis, which required a mitral valve replacement a couple years prior to this admission. She was found to have bacteremia, and she had an echocardiogram that showed a vegetation on her prosthetic mitral valve. So she was admitted. She said that she had had a relapse with her intravenous drug use, but she also expressed that she was interested in rehabilitation and treatment for her addiction. She has some family. She currently does not have a place to live, and she's unemployed. So she was hospitalized. She was undergoing antibiotic treatment, and she was referred to cardiac surgery for valve replacement surgery. So I'm going to turn it over to our panel, and I'm going to let each of them talk about their perspectives about this case.
I guess I'll go first. I guess from the perspective of those of us who provide direct care for patients, both pre and post-operatively, and in this situation with a patient who's had a relapse, what we think about is perhaps what happened the first time. And I think for many of us who've been doing this for quite some time, we have a lot of resources to manage patients post-operatively in terms of their surgical care and also their general medical issues. We know about diabetes management and COPD and all that, but we are not trained in how to take care of patients who have addiction issues. And it's particularly challenging in terms of post-operative care because patients require pain management, and there's challenges with that in terms of getting their pain off of their, or down off of their pain medicine when they're used to taking opioids. And we don't have the skill set to manage their oftentimes behavioral issues and how to get them connected with resources so that they can either initiate recovery, continue recovery, so on. So our concern has always been, it's fine to do the operation to fix the valve, but if we don't address the underlying cause, we know that these patients are at high risk for relapse. And we, as practitioners and bedside nurses, have not been in a position to provide that kind of support. And the institution at large has not had that service available on surgery up until recently. So when we think about those patients and taking care of them, I think as providers, bedside nurses, we've been particularly challenged with how to manage their addiction after surgery. Can we help them so that they don't relapse and end up like this woman coming back and needing another operation?
From a social work standpoint, it's good to provide support and be an advocate for the patient, see where the patient is in the chronic disease process of addiction, see if they're ready for recovery, and kind of meet the patient where they are at that point. Also be a link with the team and the staff, kind of bridge that gap and pull in resources that we now have available here at the Johns Hopkins Hospital. And the team's going to go into that a little bit more. But many times just helping the patient cope and come to terms with what's going on with them at the moment, realizing what the surgery will entail. If it's pre-surgery, we get to talk with them and walk them through the steps and see if they're strong enough and willing to participate in that plan of care.
Okay, good. Oh, I'm just going to echo a little bit, Krista, what you talked about. From my perspective, and I know this is a difficult population to work with, but from my perspective, having compassion, regardless of what or where they come from, is going to help ease your day and your time working with that patient and getting to know them. As you said, meeting them where they are. That is important. But also knowing up front what it is that they want. So by doing so, know what they want, you have to talk with them. You have to do a real deep, have a very deep, honest conversation and ask them, very specifically, how is it that I can help you? And begin from there. Because one of the things that the person with a substance use disorder needs, they need whole wraparound services. So we must look at the patient as a whole and begin to develop that plan.
Diane and I have been working together for a long time, so sometimes we do finish each other's sentences. And I think this is an amazing discussion, and the word compassion is there. But also, I think we need to really look at ourselves and our attitudes and our beliefs and our moral compass. And think of that person as our daughter, or our mother, or our sister. And what would we want for them? And that's how I want to be thinking about this when I'm answering my questions. I do believe that there needs to be a concurrent recovery within the hospital. While they're recovering from their surgery, they can also be recovering from their substance use. We can figure that out. We can do it. And that will improve the lives of our patients, and it will instill hope. And if you look at it from dollars and cents perspective, I also think that it will allow us to get our patients out of here earlier, and hopefully they won't be coming back. Because relapse does not need to be part of the conversation. Recovery does.
I look at things, I guess, through a less rainbow and unicorns kind of way as a person that does operations. When I first get a phone call about a 26-year-old that's recurred in terms of their IV drug use, I first look and make sure that I'm on call, because this operation is going to end up with a lot of phone calls, and a lot of responsibility, and a lot of people asking me, why did you do it? And so for that reason, it's really great to hear everyone's advocacy and compassion, and sometimes for the caregivers, it becomes a significant burden. For somebody who's 26 and who, let's just say, has heart surgery, just the disposition if they're homeless is a pretty challenging issue. If they're homeless and they're using drugs and they need IV antibiotics, that's a big issue. That being said, I always have that in the back of my mind, that I don't let that affect my patient care. What I would first do is I take a look and I say, how important is this that we do this operation right away? Endocarditis in the mitral valve position is a big deal because it can cause stroke, it can cause heart failure, it can cause arrhythmias, and all of that could lead to her death immediately. So there's no doubt doing an operation is the right thing medically. But her bigger problem is her substance abuse. This is something that's happened as a consequence of her major issues. So I can help ameliorate the medical things, but I really need a lot of guidance in getting her to what she ultimately needs.
Thank you. I'm going to open it up now to questions from the audience. We do have a microphone, and somebody will be bringing that around so that we'll be able to hear your questions.
The substitute drugs that are now to wean patients from heroin, are they injectable as well, and do they reduce the risk for endocarditis? Do they reduce the risk of contracting the infection? The substitute drugs that are now given to patients to wean them off of heroin, are they injectable? Is there a reduced risk if they're given the substitute drugs to wean them off of heroin?
I couldn't hear that.
Maybe I'll answer that one. So we're not, the major reason that patients that have prosthetic valves, or valves that are already been put, or their native valves into trouble is the use of intravenous drugs. So in the oral substitutes don't put them at risk if they're being used as part of a program, because it doesn't allow their bloodstream to be in contact with potential contaminants. I tried to make that not too medical. I hope that worked.
There we go. Given medicine's current focus on care coordination and especially interdepartmental coordination, is this something that could be fixed? Not fixed, that's not a good way to say this. Is this something that could be mitigated by working with rehabilitation centers to coordinate care between the hospital and a care center afterwards?
I think that that is the key. We always talk about having warm handoffs, but there's nothing colder than a patient going from a hospital getting IV antibiotics and then going into another facility and then continuing IV antibiotics plus their pain medicines or whatever. We're asking them to recover also from their substance use, but yet they're not getting any substance use treatment whatsoever. So that's what they're going to do. They do a great job recovering from their surgery, but you know, you take the drugs out of somebody's system, their mind is still on drugs. That will continue until there is really good substance use treatment at these facilities. And right now, I don't know of any facility that does that. I do know of facilities where there are drugs right outside of windows, where patients who have PICC lines can just reach out their screen door and get some heroin and shoot right into their PICC line. I do know that those exist, but I don't know if there's any substance use treatment that is actually being done in the facilities that we're sending these vulnerable patients to. Because no matter, if they're going to need some type of pain management, and usually they are on full opioid agonists, and they're going to need that until they recover.
I don't know if any of you remember the first day program that we had here that went defunct about 10 years ago. Diane and I both worked there, but that's exactly what we had. We had patients all day long, and they were in groups all day long. So they were getting recovery, but they were also getting their skilled nursing treatment, and they would live in recovery houses in the community.
What happened with that program?
The gap between revenue retrieval and financial deficit was too large, so it went under in 2010. And that was when we had less endocarditis, and everything has changed. The pendulum has swung. Now we're seeing many more wounds, abscesses, and endocarditis.
Is there talk of reopening that program? Since we're swinging the other way again?
I have
We're hopeful.
heard potentially there may be something from Baltimore City. I'm not certain about that, but it's will be in conjunction with maybe several hospitals or several champions for this initiative.
But if we can initiate a plan for the person with the substance use disorder with endocarditis here, and while they're and thinking that when they get transferred to one of the skilled nurses, and is having a plan where they're going to come down off of the opiates, and while they're there, giving them some recovery work, I think we stand a chance of, helping them to sustain sobriety and maintain an abstinence.
And I agree. I think that's what it's going to take, is looking at the end. When are they going to be done our antibiotics? So then that's when they're going to be discharged. So can they be tapered down off of all their full opioid agonists and then go right into Suboxone program, or they can continue with their recovery? Because recovery is a lifetime. It's not just a little piece. It's not a Polaroid. It's a big. And we have two advocates who are now working with us with care, and we are in care coordination. So we're really hoping that we can, expand under the leadership of care coordinations to make this better for the patients, because we are patient-centered.
Hello. Kind of considering what Ms. Moses was speaking about the totality of substance use disorder and how kind of maybe patient's environment and circumstances may play a part in that. Is there an opportunity preoperatively? I know postoperatively oftentimes there are family meetings, so to speak, but are there opportunities preoperatively to kind of discuss just the whole treatment plan, not only the surgery, but what's expected in terms of the 6 weeks IV antibiotics and maybe introducing a peer recovery coach preoperatively to the patient to kind of lay out that whole treatment plan for consideration prior to surgery?
I'm just going to say a couple things before Diane. Motivational interviewing, I know a lot of you have heard about it, but one of the greatest things that we can do is ask that person, so what are the good things about your IV drug use? How does that help you? And really get to know what is going on. Why is that a good thing for that person? And then what are the not so good things? So that you got some meat. You got your meat and potatoes you can start working with, and then you can start helping them with that recovery process. That's where we have to begin.
And if we know that they can't go to the skilled nursing center because they've been there before and they shot out some drugs and across the board, nobody want them back. So we can initiate some groups in-house, some individual one-on-one sessions with the patient, as well as, again, emphasize the importance of doing recovery. Because if they don't do work on themselves internally, then it's not going to work. Because as Patty was talking about, we're not helping change in their thinking, and that's the most important thing with the person with a substance use disorder. We got to help change their thinking.
We've also had a few of our surgeons have had some patients boarded over on the medicine side to get these consults in prior, and also try to get a plan together if it's not so emergent. And then we do bring them over to surgery, do the surgery, transfer back over to medicine as well. So we've had 1 or 2 cases, and also some of the surgeons have called ethics consults as well, so we can have that communication.
Yes, my name is Elisa Yeshus. I'm an infectious disease fellow. I'm here with some other folks from the ID department. And this is just such a wonderful discussion. This is a subject that we talk about probably on a weekly basis in our divisional meetings. So I'm really glad that there's all these folks with different perspectives here to comment on this complex issue. From our perspective, there are many cases that we sort of visit, and the ones that trouble us most, I think, are where there's appears to be a lack of standardization in how the case is approached and how that calculus about surgery is eventually made. It seems that lack of standardization offers the opportunity for the introduction of biases potentially. And so those biases can either be geographic, we rotate at Bayview, and just the fact that there aren't surgical services directly there, and that conversations often are done remotely, can be theoretically at least problematic. I just was curious if between all the bodies represented here, if there had been discussion about some sort of protocolization in how the assessment is done, something that does take into account prior substance abuse history, perception of family stability, interest, motivation to cease from drug use, as well as, from our perspective, some calculus about the actual pathogen that's causing the infection, since that does drastically change kind of the acute morbidity, the absolute need for valve replacement, things like that. That have been something that have been discussed between the surgical, medical, and ethical bodies that are involved in this one.
That's a great comment and great insight. Unfortunately, we don't have a protocol. I think that's what we're trying to strive to. In this clinical vignette we came up with maybe 2 months ago, but I think you guys are involved in a patient in the NICU right now who's exactly this person. This 26-year-old has left AMA a couple times, and the bug is something that's not going to get treated with antibiotics. And I'm up here saying, what am I going to do? I can't change her behavior. She's in the medicine service. I've asked everybody involved here to go see her, but there's a significant compartmentalization, so to speak, of services. In the NICU, you get to take care of the medicine team. They're not necessarily in tune with some of the surgical things. From an ID standpoint, you look at whether or not the bug is something that is clear. I look at it from the point of whether or not I can take care of it. The ethical stuff is really hard. Right? There is no cookie-cutter way of saying what, describing who's going to do well and who's not going to do well. At the same time, I don't like feeling like I'm the one in the spotlight that has to unilaterally make a decision of what's right and what's wrong. We've talked about this from our own division, from surgical thing, and 6 of us can't even agree on what the right thing is. We have compelling arguments. Every time you go and you talk to somebody, you say, oh, I believe this person's going to do okay. And I think that's a great call, and I think it's a great call for unification and kind of collaboration between all the different specialties and different things that are involved in taking care of these patients.
I was wondering, actually specifically from the surgical perspective, are there any more risk, greater risks on redoing the same procedure that was done the first time? Is it any more complicated from the procedure perspective or a greater risk for the patient?
Absolutely. Anytime you have a re-operation, it's more difficult than the first operation. So in this specific case, the mitral valve, you have to take out the previous mitral valve, so there's a chance of emboli, causing stroke, causing renal dysfunction, splenic infarcts, distal leg embolizations. You have to debride the tissue, so if it's starting to eat away at the heart, there's a higher chance of needing a pacemaker, which is a significant thing in somebody who has probably questionable IV access and things like that, and there's another nidus that can get infected down the road. So certainly, it's not the same. Prosthetic valve endocarditis has a significant mortality, even without our big issue, which is utilizing IV drug use. Different valves have different complications involved in it. Valves that are on the right side, that are not in circulation with the systemic circulation, but with the right side and the lungs, they tend to be a little bit more tolerable in patients. But an aortic valve and a mitral valve are a little bit more effective, especially in the operation setting.
is there like a physiological limit of 2 replacements, 3 replacements, or do we know the limit yet?
I don't think there's a limit. I've certainly done operations where it's a 6th time going back into the chest and people can be okay with it. It's the physiologic reserve. Certainly things that would be hard stops. Let's say she came in with a embolization to her head and had a head bleed. And there's very specific details and different things, so it's hard to protocolize everything for those reasons. But I think it's also important to know what the potential recovery and potential limitations will be in somebody that's already in a difficult position.
So I wonder if you could, I'm sure we're not the only ones that are struggling with this question. What's happening nationally in terms of cardiac surgery and others who are involved in these kinds of cases and situations? Is there a national dialogue that is happening, and if so, have any recommendations been made, any consensus that has emerged?
I feel like I'm hogging the microphone here, but there is a need for these discussions. I'm really glad that we're doing it here. Part of the STS committee, the Society for Vascular, one of the 2 big meetings that we had, and we actually put it on the panel this year. We said this is very important that we hear from an ethicist on what is and what isn't okay. Because we know the frustration we have from just our side of things, not everything else that's also involved. But some people say you can offer them another operation within a year. Some people say you can offer them an operation if they say they're going to quit. Some people say I won't operate on anybody that hasn't gone through a program. And I have other people who say we'll operate on them as long as it takes, because it's really not their disease, it's a consequence of their disease. So we're really having internal debates, and some people use the argument, if someone tries to commit suicide and jumps off a building, are you not going to set their bones to save their life? If someone who's in prison keeps ingesting razor blades and they need an expiratory laparotomy to take out this razor blade, are you going to stop doing it at some point? So there's lots of different discussions that are not just significant endocarditis and drug use, but personal harm and what you should and shouldn't do.
Hi there. I was just wondering, what would the most ideal treatment plan be then for a patient who came into the ER over the course of their antibiotics? What kind of services would you like to give this patient in the ideal situation?
Well, I would like to see, first and foremost, the first step they ask them, where they're going to be getting integrated care. They're going to have OT, PT, individual counseling, they're going to have family counseling, they're going to have one-on-one. They're going to be able to go off the floor to meetings, or either have the meetings come to them. They're going to be doing step work, they're going to be doing homework. So we're constantly going to be inside of their head trying to figure out, what's the next step for them. And any family members who are supportive, if they have a family member, because you have to remember, a lot of people with substance use disorders had burnt bridges and families. They have torn them apart. I'm quite sure everybody in here has somebody or knows somebody with a substance use disorder. And given the climates in the United States today, where we at right now, with 70,000 last year with overdoses, this is nothing. We're going to see a whole lot more. So we need to come up with integrated care.
I think one of the other main issues postoperatively, we see this on the CBPCU, is the pain management and coming up with a plan to manage their acute pain and then weaning them off. And we have the ability with the acute pain service to get them on a regimen, but our problem is then how do we get them off that regimen? And how do we potentially transition them to Suboxone? There is an initiative to get advanced practice folks trained to be able to initiate Suboxone in the hospital, which we currently are not able to do. We cannot initiate methadone for withdrawal prevention or for maintenance therapy. We can do it only for pain. So some of the challenges that we have are just what next. And we also have controversy within our amongst our providers or between the nurses on how to do this. And patients can be very challenging with their behaviors overcame meds. And we really need some support with that. And that's an initiative, I think, hopefully with the substance use disorder group that we can begin to look at as well. So that patients also are going out with a plan about how to get weaned off when they're in these facilities.
We also now have the aftercare clinic over at Jayhawk, which has been a good link. And they can assist with the medication-assisted treatment programs. And that can be a link upon discharge from our unit to the aftercare clinic and hopefully then to a clinic in the community and a program that would work for the patient as well. Because sometimes there is a gap in timing, but we can get appointments very quickly at the aftercare clinic. And that has helped a few of our patients most recently.
And also for the ones that do go to the skilled nursing center and who are going to stay out the 6 weeks course, we need to be thinking about having somebody come to them. Because a lot of times at those places, they're not properly detoxed. And so they return back to that same old use. But we can have someone to come to them, like our peer recovery coaches, which we are looking into in the future. Having them go on and meet with them once a week, twice a week, just to talk about their next step in the recovery process.
What about establishing a clinic where they have a sterile environment to use the drugs and in that way preventing the infection? And what are the ethical implications of that? And secondly, is there a pill form of antibiotics that can be used prophylactically once you know somebody is addicted to intravenous drugs to prevent that from happening, to prevent, I mean, I'm thinking that whole emphasis on meet them where they're at would kind of indicate that you would make the environment sterile for them if that's where they're at, so they don't then develop the infection.
Well, there's no such thing as sterile environment when somebody's doing substance use. Because again, the pathology of a person with a substance use disorder, they're going to do drugs any way they want to do them. It doesn't matter. You know, so there are medication-assisted treatment. You do have methadone and you have Suboxone, you know, that they can take, you know, outside of that. But those pills don't mean nothing if they don't have therapy. They mean nothing. It's going to stop one behavior, but it's going to continue. Their thinking is going to continue. So, you know, they need, again, like you were alluding to, they need the wraparound services. They need the therapy. Pills are not going to work without the therapy.
I think it's a good question, though, because we know, and I think Diane and Patty can address this, there are patients who are going to relapse and patients who are probably going to never stop using. I don't think in the U.S. there are any programs, but I know in Canada they have clinics that they've established where patients can actually go and inject their heroin. So it's clean needles, it's a sterile. Yeah.
Self-injection site.
Yeah. So there are more and more of those coming actually in Canada. I think the U.S. is pretty far in. It's a good point. And of course there are clean needle exchange programs available. And I guess it's reasonable to discuss that with patients as well. Even though we want them in recovery, we know that they could relapse. So if they're going to use it, I had a patient who was a second time valve replacement, and she said to me, "Boy, I didn't know this could happen. Like, I didn't understand that I could get my valve infected." So, you know, I don't know what kind of information is out on the streets with people. They really understand. I mean, obviously, when you want to get high, you're not really thinking about, you know, oh, I could get endocarditis, but you know, people are going to use certainly clean needles is a better way to go.
And I'm just going to backtrack a little bit to when you had said, you know, you would encourage these patients to go to meetings and go off the floor. And typically, we don't allow these patients to go off the floor unaccompanied. And I didn't know, you know, we're still learning the role of peer recovery coach. Is it an option, or could it possibly be an option to have a peer recovery coach be the person accompanying these patients to meetings?
Absolutely. I mean, that's where we're looking forward to implementing that kind of services. You know, they're new to our care coordination, but we're definitely looking at that role. We only have a couple NA meetings on the site, you know, so there's one on Sundays at 3 o'clock. It's a really big meeting in the Hurd Hall. And then they have an AA meetings in the Maya 191, that's 8:30 on Saturdays. The other meetings take place in the Department of Psychiatry on the floor. So again, we might want to think about implementing a meeting, having that INH meeting where someone comes to surgery and they can have a meeting there on the floor.
I think we've been talking about patients that are willing for treatment. I think one of our biggest frustrations on the CDPCU are the patients that are outright telling us, like, I'm not going to stop. And so what do we do there when they're refusing meetings or peer counseling? They don't want to do rehab, they just want you to fix their valve and let them go back out. So what are our steps then?
Keep on talking to them. Actually, one of them wants to stop. Talk with them, not at them. Talk with them. See, when you talk with them, you will get more substance. You know, a lot of times we tend to talk at them because out of frustration, because they, you know, they're difficult patients. But talk with them. You know, just keep on asking why. And if you have the opportunity to work with them for their duration, that'd be great. You know, because they will say, oh, somebody listens. I think they like me. Because they're already defensive off the bat because of the stigma that we have placed on them.
And somebody may just be saying that just to get you off their back, because they know that you won't continue to ask those questions. That's when I ask, so why? What are the good things? What are you enjoying about using? I want you to write these things down. Give me a little bit of information about how you got started and really get to know that person. Because I don't know anybody who would say that they want to continue if you really get down to what happened. I'm not going to get into all the, you know, the trauma and all other stuff that often comes up when it comes to substance use, but there's usually other issues that need to be addressed that can't always be addressed here in this little short hospitalization. And we certainly don't want to open a Pandora's box, but we would like to at least start to uncover and unravel and be able to get the conversation started for that person so that they know that there is hope, because they're living in a situation where they are hopeless and helpless. And the hospital may be the only protective environment that they actually know. There are survivors on the streets, and they have more street skills than I will ever have. And boy, do they know how to make a chaotic situation real quick, and how to staff split, and because they're used to doing things and getting their ways, and they're very good at it. And how do we help them?
Rediscover their dignity as a person. It's our obligation as providers.
Hi, I'm Julia. I'm also one of the ID fellows here, in my third year. And as my co-fellow Elisa said earlier, one of the frustrations for us in working with these patients is the lack of standardization and protocol involved in decision making. And especially with all of the expertise that we have in the institution, it can be difficult to coordinate between all of the different services. And I also agree with the assertion of our colleague that a lot of the burden of decision making in these cases falls on the surgical team. One approach to this that I've heard of at familiar with from other institutions is to have a weekly working group between the social workers, peer recovery coaches, the surgical team, and the infectious disease team to work through, much like a transplant decision apparatus, where the cases are discussed and the decisions are made on the next steps. And I'd be interested to hear what your thoughts are on a more collaborative approach to decision making for these patients.
So we have been having weekly meetings since the SUDS team has rolled out on the surgery side. we're trying to pull in many different disciplines at that meeting. It's not a plan of care meeting per se for each patient that's experiencing this issue, but more to pull together the interdisciplinary teams that are working on each of these patients and come up with a protocol that would work. So we've been doing that for about the last 2 months, I would say. Every Wednesday from 11 to 11:30 with the 10 West and 11 East teams. And we're trying to move forward from there. We've had the outpatient physician, Dr. Rosalind Stewart, has attended that as well. And some of the pain management folks, as well as case managers, social workers. We're trying to pull other staff into those meetings as well, because we're really trying to get together a better protocol and plan of care for these patients. We're just shooting in the dark each time the patient comes across at rounds each morning. So that's basically what we're doing now. But I hear what you're saying. You want an individual meeting based on each patient. I know at rounds we try to do that, but we haven't gotten there as of yet.
What's the volume like? How many?
Add a different, sort of a different perspective. When I think about the ethical issues at play, I think maybe what's not ethical is for the provider team to be put in the position of making decisions when they cannot control or even offer so many of the wraparound services that are needed. They are so presented with a personal situation that on an individual basis will result in compassion and frustration and sadness. But I'm not sure if this is really an ethical issue for the clinical team to decide, or whether the whole system creates this is an ethical issue. And the provider team can do the best it can do, but it should not feel that it is ethically required to make this determination, because there are just too many elements of it that are so broken. So I don't think the ethical issue is the case study. I think the ethical issue is that we even have this issue that we're asking the providers to deal with this chaotic system. And the patients are absolutely at the mercy of this very troubled socioeconomic situation, community situation, lack of resources. I think it's an impossible situation. So a different ethical situation than I think the way this has been presented today.
Dovetail on that comment. I have a lot of respect for our presenters from cardiology for making this an ethical issue. Because if we don't, insurance will. There's going to come a time where, and I think it's going to be real soon, that insurance companies are going to say, we're not paying for this again. We paid for it once already, and if there's been a relapse, due to substance abuse, we have CRISP available to us. So I'm sitting here being so curious about how long it took for the patient to relapse. So there's other information that's not being presented. I'm sure you're all working on, but I do respect you for doing what you're doing. You need to, because insurance is right around the corner for denying a second one.
Before insurance denies the second one, I think we need to also look at what are we doing for that patient while they're here in the hospital after pre and post first one. And I don't know that I'm not on the floors. Hopefully we will be, and we will be able to make an impact. But right now, we don't have the manpower to do that with our team. We have Diane and I, and 3 peer recovery specialists from the hospital for 13 medical floors and 2 surgical floors. So there are patients we don't even get to see. But I would like that one day we will be able to take care of those patients from the minute they hit the hospital floor prior to their initial valve replacement surgery.
I think that brings up a good point of, since there are limited resources now, how other individuals can be trained. Can providers be trained to do a better assessment of patients prior to surgery, a more comprehensive substance use history? And then how do we train the staff, including providers and bedside nurses, to manage behavioral issues that we've addressed as being particularly problematic? So I think there's certainly room for that, and we have our very talented colleagues here that can help us with that as we move forward, because I don't know that there's going to be a great influx of resources at this point. I think we have to certainly demonstrate that we're making a difference. But I think in the interim, we can certainly do work to improve what we're doing now. I think it would be great to have a preoperative assessment of at least some of the most perhaps problematic patients that we can talk about comprehensively on the medicine side, on the surgical side, social work, substance use team, that we can make some assessments of patients even prior to surgery and make a better informed decision about their plan of care as we move forward.
Hi, my name is Joyce, and prior to joining the Hopkins team, I was a social work manager for a rehab center. And just to piggyback on from the question or comment prior to me, I think what we face as social workers at a rehab center was a lot of times the patients were coming to us and they had gone through that first stage of withdrawal where they have these symptoms. So a lot of times the insurance companies are saying, okay, so what symptoms do you have? What do you see? And it's like, well, they've pretty much gone through the big phase, which would be, again, the side effects, they're lethargic, just what you see on a regular basis. So a lot of the problems that we faced was we didn't have what we needed in order to enroll someone into a substance abuse program, because they have gone through maybe a week or so at the hospital, and then they're coming to us, they're not quite there, but the insurance companies want them to be at an area where they are absolutely can't do anything for themselves while they're with us, and they can at least they can walk with their feet. So I think my suggestion would be that a lot of these patients go straight into the substance abuse programs from the hospital setting. Because coming to rehab, a lot of times they have passed through that stage or that phase where the insurance companies need them to be. And unfortunately for us, well, for me at that time, we're unable to do anything at that point. So we have to think about insurance companies, and a lot of these managed care insurance companies are not going to cover someone that can walk. Okay, so if you're walking, why do you want to send to rehab to substance abuse program? So just a comment from my experience.
Yeah. So you might want to, at your facility or moving forward, the social workers might want to develop a resource guide so that they can begin that process while they're there. Calling around and seeing if they want medication-assisted treatment, or if they just want to continue with rehab, where there's no drugs and they're just doing the recovery work. Because a lot of facilities, social workers are not trained, so to say, to deal with substance use disorders, and so a lot of times they just go on out the door.
So, sorry, but what I was saying is it's better for them to go into a substance abuse program from the hospital.
No, not if they need it. If they need IV antibiotics, they can.
Right.
Oh, that's the other problem. So.
Yeah, most of our patients, after they've had their surgery, need 4, 6, or 8 weeks of IV antibiotics, so that we have a gap. So when Patty and Diane were talking about a program that could encompass everything while they're undergoing the IV antibiotics with assistance with their addiction, that's what we would like to see put into place. Because if you have the buy-in from the patient for that period of time, 4, 6, or 8 weeks, you could really start to get started on the recovery process if they're willing to start that. You have captive audience for the IV antibiotics. And if we can get the services in there at the same time, that would really help them. And then upon discharge from the IV antibiotics, wherever they are with that, they could go into a program that would link them into the next stage of recovery.
Well, I guess then my question is, do we know whether or not the hospital has started to engage communities, skilled nursing facilities with having that discussion, setting up that partnership? Like we have partnerships with other facilities that specializes in rehab, that specializes in pulmonary rehab. So do we know whether or not the hospital is starting or having any sort of plans to create exactly what you're speaking of, that I think is next step?
I do know of one committee that's working, moving towards that.
I think care management is looking at creating liaisons with certain skilled nursing facilities where they can begin doing recovery for those patients. And those facilities would be ideally where we would send our patients. I think it's just in the planning phases.
Hi, thank you all for doing this panel. I find this very valuable as a new green social worker with not a lot of experience in substance use, but finding that a lot of my patients in cardiology have used substances in the past, leading them to heart failure or endocarditis or whatever it may be. Just curious, because ethically this is challenging. The social worker in me is like, you should do the surgery no matter what, give them as many chances as they need. It is a disease, it is not a choice. I'm curious for the physicians that surgeons, that have decided they won't operate unless there's been some type of rehabilitation and recovery shown on the behalf of the patient prior to surgery. If there's been more success seen in that rate, like maybe less valve replacements having to be done, less infections. If I know you said that it can often be something where it has to be done right away because they could have a stroke, they could die. But I'm curious rehab now, it's not very long, but if a patient discovers that they do need a valve replacement and the team sits down with them and says, okay, well, here are your options for treatment, and we find that the success rate is higher if you're interested in recovery, going to treatment first, and then having the surgery. Because in my mind, just thinking about if I were a drug user, being told that I was going to be on multiple weeks of IV antibiotics, that's just like a sign to continue using almost, especially because it sounds like once they are discharged to a facility, they're not getting the support that they need. Because as Diane said, the Suboxone is just like a piece of the puzzle to their recovery. The therapy and the group counseling, and that is huge in recovery. And if they're not getting that because they have to go to a facility for 4, 6, 8 weeks, that's just setting them up for failure almost. Just is what I'm thinking out loud here. So I'm curious on your thoughts to that as well.
Sorry, they cut off my mic. They don't want me to talk anymore. It's difficult, right? I think we're all saying the same thing, which is we need to do more preoperatively. There is no measure of how to be successful. One of the other hats I wear is our ID colleagues have said, I sit on the VAD and heart transplant committee, and oftentimes we know these patients for months, if not years in advance. So it can say things like you need to be abstinence from X, Y, or Z, you need to be involved in this rehab program. Endocarditis, unfortunately, doesn't necessarily present that way. Some of it's really acute with full-blown heart failure and things like that where you don't have that luxury. In patients that have maybe not extremis, and let's say in a favorable valve position with favorable pathology, that'd be wonderful. I don't know who's going to pay for that. I don't know how we're going to enroll them in that kind of program. I have certainly changed my views because exactly what happens in the CVPCU in the splitting. When I talk to a patient, no matter what I say, everyone seems to try to please me They say, absolutely, I'll stop drugs, I'll never use again. And then I walk out of there feeling pretty good about myself, and I say, I changed that life, let's go do this vale. So for that reason, I used to say, if they come back in within a year and they've used, I have had that talk with them. If I can't change them, then that's all I'm going to do. In fact, I think that's flawed. I think that is setting them up for disaster, it is setting them up for failure, and I'm not good at those talks. I'm not good at getting to the meat of things of, can we or can we not do that? So there's significant value in doing things preoperatively before you give them a big sternotomy, have tubes coming out of them, give them real pain, and then say, let's talk about how you're going to stop using things. So that the preoperative phase, I think we need to do a lot better, and I think we need to have serious discussions, which I know I'm not good at, and I'm not the person.
Well, thank you. We appreciate the panel's perspectives on this topic, and thank you to everybody who participated and asked questions. We certainly are learning a lot as we go along. It's evolving, and we do understand that it really is a multidisciplinary approach, and we need to keep asking the questions about our patients. One of the references was not from this country, but they did try sort of a multidisciplinary assessment of patients preoperatively, so I found that interesting, so you may want to look at that. And if we don't have any other questions, thank you again to our panel, and thank you.